For the autonomics, you mentioned it controls swallowing. What do we need to know anything about, like, is it the dorsal vagal nuclei that's involved with that?
Actually, the bulk of that is going to be through the nucleus ambiguous, but yeah, in terms of the autonomic, which is the automatic part of swallowing, because you have a voluntary piece, well, that's all I wanted you to know, that you had this input that did have something to do with swallowing. That's it.
Okay.
One of your questions meant that the facial nerve is associated with the nucleus tractus solitarius. Is that because there's a pathway that leads from that to the facial nerve?
Question is, one of the questions that cranial nerve 7 had something to do with the nucleus tractus solitarius. And the deal there is that if you've got GVE, you've got GVA. And GVA all goes to ENTF.
Technically, I mean, they can almost associate anything with anything. Maybe you stretch it. You know what I'm saying? You keep stretching.
Well, within the brain, it's been said that you can get anywhere within 3 neurons. So yeah, but that's not where we're going with this. Within the realm of how I've presented the autonomics, if it has GBE, it has GBA, so there's only 4 cranial nerves. Well, 4 cranial parasympathetic related. So you get 3, 7, 9, and 10, and in the head you've got the 4 parasympathetic ganglia. That's what I'm referring to. If you're talking about sympathetics, you've got the same sort of thing, but you're talking about T1 to L2, and you're talking specifically about efferent sympathetics are going to have afferent sympathetics.
So all the sympathetics would be involved. Or would, so the question is, where is the nuclei associated with any autonomic nerve, right?
Right.
Always include the nucleus tractus solitarius.
Correct. For either sympathetic or parasympathetic, doesn't matter. It would include NTS.
Is there any other nuclei we should know that like a catch-all like that?
I don't know that I gave you anything else like that. Remember, that was one of those all statements. Yeah. It's rare that you can say that. That's one place where I stressed it a lot.
Mastication is severe and specialized motor function. Is that still cortico-bulbar system? Mastication?
Mastication, from the standpoint that you're involving cranial nerves for mastication, yes. So, yeah, trigeminal system primarily, if you're talking about the technical, muscles of mastication, and expand that to include a few other things, but anything involved with mastication, yes, those are cranial nerves having to do with movement of the oral cavity for the most part. You do have a few things that come off of super. Yes. Does that make sense? To what extent do I want you to know this? If it has to do with the oral cavity, I want you to be aware of it. Okay? So that way you can eliminate anything that doesn't have anything to do with the oral cavity.
Of the areas in the brain, do we need to be able to tell you the point of attention of where they are, or just know they are connected to each other?
Yeah, that would be an easy question, is to actually point out some of those areas, Broca, Wernicke's.
Are any of them in the frontal lobe, or are they all of them in the parietal and
Broca is in the frontal, precentral's in the frontal, which is area 4, area 6 is premotor, that's there.
and also, could you maybe go into detail the differences between area 39 and area 40?
Differences between area 39 and area 40. Because of one of the questions that I put in there, and I didn't make it probably, I changed the way I lectured on that this year. But if you look at the question, first off, it's talking about behavior. Behavior is frontal lobe. It has nothing to do with precentral or postcentral gyrus, but it has to do with the anterior portion of the frontal lobe. in that sense, is that the part you're talking about, or is it, okay, never mind. I'll go with that one if somebody else wants that one. 39 and 40. 39 I definitely gave you is dyslexia. Dyslexia is visual. Question is, what's 40? And 40 is being able to interpret, to be able to put down symbols. And so that's what I didn't make clear in, so that's one of the two things I didn't make clear in my lectures this year compared to the way I taught that the previous year. So I said 40 and 39 are linked, and the way that question is worded is, if I remember correctly, it's talking about if someone asks you to do something, that's an auditory thing. Didn't ask you to read it. I mean, it didn't say read it and then interpret it or something. It says you ask someone, which means they're having to interpret what you're asking. So it's going through Wernicke's to 40, which hooks up with 39, and that all works together. So that's why that question is worded that way. It just wasn't clear probably from my lesson.
Is that the same question that you're talking about where you took the word tweet and they were supposed
Yes.
to write it out? So the reasoning for that isn't because like the three looks like an E such a symbol?
Right, because
Is that the
you
reason?
asked someone something. That's what the question starts with.
Okay.
You asked them to do something.
So the tweet and like the.
It
tweet
wasn't
three
that they
has
read
nothing
it
to do with
wrong. Correct.
Okay.
So 40 is the interpretation of the symbols. In this case, it's trying to interpret the auditory symbol, and you're trying to, or whatever the person is trying to write symbols. It's got nothing to do with reading symbols. The big thing is you're not asking them to read it. They're not misreading it. They're mishearing what they have to do, and inability to do that.
So 39 we're associating with reading and 40 we're associating with hearing?
Hearing and or writing, you're trying to interpret a symbol also, so they weren't able to write appropriately. So 40 works that way between Wernicke's and 39. It's interpreting symbols, but it's not interpreting the reading symbols, it's interpreting other symbols. The ability to express by writing can be messed up, and that can be also messed up because of inappropriate Wernicke's. So it's kind of like in between Wernicke's and dyslexia, 39. 40 is kind of that in between for symbols. If it's not reading, it's something else with the symbol. So that wasn't clear. I understand that. As was the thing I started to answer for you, which was having to do with behavior and frontal lobe. So, which had to do actually with the, now that I'm thinking about it clearly, I hope, anterior middle cerebral artery, that question. And which artery is it that's responsible for the frontal lobe behavior? And I didn't make that clear as to if it's one or the other. Actually, it would be both. But for occipital lobe, I said just make it posterior cerebral. But I didn't say something like that for the frontal lobe, which is why that particular question, the way, at least the way the answer says only anterior, you're going, why is it only anterior? It would be anterior. So I'm aware of those things, and I will try to be aware of that in the way I've written the exam, so I'm not going to trip up anything. Anterior middle, but I'm not going, I understand that I'm not talking to the entire class, which means I'd be giving you information they may not have. So I know that, and I'm not going, I'm trying to write the exam so that won't be an issue. Okay? I did write the exam, believe it or not. It actually went to the printer, yes.
So the difference between aphasia and hypnosis,
because, it does interact with 39.
So it's both agnosia and,
It is, it is, period. One of those things, you can't just take your brain and make it fit into anything straightforward. Right.
For the limbic structures and for Robin's brain, would you be able to identify where the limbic structures are and where the areas are specifically? I
Well,
know Carla kind of asked me similar, but.
I didn't show you all of the limbic structures, but within the cross sections that I've asked you, the 3 cross sections, yeah, I mean, you should know where the amygdala is.
So like no, like 17 amygdala?
Yeah, 17's amygdala, you're right.
Okay, and then another question, for the basal ganglia, I was kind of always understood there was like 9 and 10, the little candy corn looking thing.
Yes.
I thought that was the basal ganglia, but you said in the notes that basal ganglia includes like the amygdala and all those things. So is it that broad area or is it the candy corn?
It's all of this,
that sounds really fun.
it's collective, it's multiple nuclei.
Okay,
So basal ganglia is a collective term for all of those areas,
okay,
not just one or the other.
okay.
Is the amygdala part of the limbic structures list and the basal ganglia list?
Yeah.
Do you go over the GVA pathway for like head and manhood? I think there was a question about the DRG.
There is no difference between the two. The question is, if you didn't hear, she asked, if I heard you correctly, go over the pathway for GVA
Like where the
for
cell
head and non-head.
Sorry, I
Where are
think
the
I
cell
meant-
bodies?
yeah, like
I know
what-
what you're talking about,
yeah,
but you
yeah.
wrote that down too. Where are the GVA cell bodies?
Oh, okay. GVA for non-head is going to be dorsal root ganglia, and for head it will be the cranial nerve ganglia that's involved with the parasympathetic.
So it's just like afferent that are just plain sensory?
I'm sorry?
So it's just like normal sensory afferent things?
Yeah,
Okay.
yeah, that's, and that gets confusing, because that goes back to the second lecture in growth. If we're talking GVA, where are the cell bodies?
Right.
For sympathetic or parasympathetic? Yes. Correct. The non-head will be in dorsal root ganglion, that's where the cell bodies are. And in the head, they'll be in the cranial nerve ganglia that have parasympathetic. Sympathetics are all in juvenile too.
Same process with the reflex, you mentioned that some of them can skip like limbic system, they can hear directly down,
Yeah.
they're more like autonomic reflex.
Right.
Do they still pass through the NTS?
Yes.
Okay, they just
When you say pass, they will synapse there.
synapse with the NTS and then they,
The GVA will synapse on an NTS cell body, and that will have an axon that goes down to the preganglionic autonomic.
so it just skips, it still synapses in the NTS. it
It's a
doesn't
reflex,
fill up.
correct. It's a reflex, so it bypasses the limbic system. And a few students have asked about that, and I think about it in terms of oxygen or carbon dioxide level. So you've got an automatic feedback and reflex in terms of respiration. Okay? Well, what if you involve some limbic structures and you have the amygdala involved with some fear? Well, now you're going to change your respiration rate, and so you're modifying that reflex. Okay, so that's how the two things kind of work with each other. Katie and then Becky.
Okay, sorry, I didn't catch it. Did you say that sympathetic synapse, like synapse in the NTS, or no?
No,
You don't have sympathetics in the NTS?
sympathetics are efferent,
Okay, there's no afferent, okay.
but within the nerve bundle, that sympathetics are going out from the spinal cord will be sensory afferents. Does that make sense? It's those that we're talking about that go to the NTS, the afferents. Okay?
Okay, going to the last lecture over non-head pain and head pain,
Mhm.
we talked about in the dull pain, that they have collateral, is there any significance to that? And also, do sharp and dull always have to occur together?
To the first question, is there anything with the collaterals? And yes, there is importance to it that we'll get to in a different lecture. So you don't have to worry about it too much. In terms of your second question, if I can remember it, sharp and dull, can they happen separately? And the answer is yes. That gets to what modalities are. And that goes back to the beginning when we talked about sensory modalities. If you think about pain, there are different kinds of pain, and you talk about the receptors. So you can talk about those different modalities. Okay? So you can have thermal pain, cold pain, hot pain. Those are all different modalities, and they can all happen separately. Depends on the condition. The question was, hot can be sharp, and that just is how you're put together. You do have A deltas that do respond to hot pain, but you also have C fibers. So it can be both. But yes, if you can stimulate the one, you can have just that one.
So the sharp, if they were to get a sharp, would be very similar, and be like a fast speed and the dull would be second.
Right, in terms of the two pain system, the sharp pain is going to be the faster one. But understand that when you say it happens first, when you're closer to the brain, the difference between first and second is very
And enters, what, it has the red thing, what is it entering through, what is that? It's going to the dorsal horn of the synapse, but what's the tract called?
What's the tract called? It's the tract of Lissauer, but you don't have to know the name.
Alright, so I don't have to know.
No, just that's where they are.
Okay.
Yeah, for those who like completeness, there you go, you're right there. There were hands. I mean,
Okay, so on the ventral trigeminal and the paleo-trigeminal, on cross-section 6, like I thought there wouldn't be anything going to do with the actual spinal cord. As a yellow.
very, very sharp that you noticed that the spinal cord is involved, and that I haven't discussed yet. So we don't have to worry about it for long. And I will bring that in and why that's important later.
But what's happening in cross-section above that? Is the spinal nucleus?
Yes, this is spinal.
I have a question. For the secondary cell bodies, when talking about the cortical bulbar pathway, so you have that primary cell body and then you have the bilateral innervations. So the secondary cell bodies, are those in the cranial nerve nuclei?
Okay, let's back up.
Okay.
Which pathway are we talking about?
Cortical bulbar pathway?
Cortical bulbar, okay.
And so you have, in the picture that you drew with like the smiley face on top, you divided it in half and said, some of them are bilateral and only
Yes.
two were contralateral. So the secondary cell bodies, they're located in those cranial nerve nuclei,
The motor nuclei.
the motor nuclei.
The motor nuclei, yes.
Okay. And do we have to know those names of nuclei?
Sure.
Sure.
Cranial nerve 3, motor nucleus,
Okay.
trigeminal motor nucleus.
Alright. Thank you.
Correct. Just repeating GBAs and cranial nerves, that if you have GBE, you have GBA. Agree? Yeah.
So back to that, sympathetics are parents, so they can have bypass.
Alright. Your arm's coming out of my video.
Go back to the spinal cord. You're in the lateral horn. NTS is up in the brainstem. Okay? Huge difference in, okay? So sympathetics are in the lateral horn, they go out to the body and do their thing. Got nothing to do with NTS. What it has to do with is the GVA that are also those axons. that are tied up with the sympathetic axons. Now, we don't call them sympathetic sensory nerves, but that's kind of what they are. We just call them GBA. Okay? So they're the ones that are going to go up to NTS. Does that make sense? That they're kind of tied together out in the body. One going out, efferents, sympathetics in this case, and the afferents of the sensory component, and they're just the axons just tied up in the same bundle. Okay? And so it's the afferents that are going to go up to NTS. Nothing to do with the efferents, other than out in the body, they're tied up together. So when I asked the question about cranial nerve 7, it was, they're tied up together, okay, in the head, but the sensory component goes to the NTS, the brain. Okay? Right. I'm afraid I'm making it confusing, and I'm not trying to be, so if there's something else, I can explain, I'm trying to.
I was just thinking, maybe if there's like an example of when that would be used, that pathway, because I think I'm having trouble with this chart as well. The GVAs going into NTS, and like where the GVs come in. It's like maybe like a real life example might help.
Yeah.
Maybe.
How about the test question?
Or that would be good.
Well, I gave one, and that's why I'm not so sure
Okay.
how to.
I just don't think it's clicking yet.
Yeah, I agree.
Okay, you have respiratory nerves, right? And they're sensing your respiration rate, or they're sensing, in the example I gave, was oxygen.
So you have like GVA receptors in your lungs.
In your lungs,
They
or the
can
carotid
tell.
body, somewhere that it can sense this.
Okay.
Right. And so they will follow and go back into the CNS. Now, depending on what part of the body you're in, they may enter the spinal cord, or they may enter the brainstem. That's just where they're entering. But they will find their way then up to the NTS, and that's where they will synapse, the sensory component.
So that's just like one neuron? Or there?
One neuron, yeah.
Okay.
But you're talking about a bunch of them from all over the body, but they all go to the NTS. So in this example, then you have a reflex of saying, okay, let's say you've been hyperventilating for some reason, or maybe you've been running, and you're at oxygen deficit. So you start to breathe more heavily. And so there's a reflex to say you're in oxygen deficit, you need to breathe more heavily. And so this input goes to the NTS, reflexively goes back down to say increase your respiration rate. So that's the reflex piece. It just automatically happens. Versus that you have this information going from the NTS up to limbic structures, and I don't know, because I just put you in oxygen deficit. Well, how do I calm you down real quick? But if you had an emotional change, it could modify the way you breathe. Okay, so it's the limbic emotional piece that can come back down and modify in the NTS that's going to go out to the body. Okay? So that's all I meant by that diagram. I was just trying to simplify how you had reflex versus you had a limbic input.
Okay, so that GVA would go to like the lateral horn,
Yeah.
or to the,
Or to Edinburgh-Westphal, or to dorsal motor nucleus of the vagus, yes.
which is the primary body of the GVE,
Correct.
preganglionic, and then you synapse somewhere else.
Right. To respond appropriately in the autonomic condition.
Gotcha.
So the GVA and the GVA, or the GVA and the GVE are both leaving the NTS, or the GVA leaves the NTS and goes to the primary cell body of the GVE?
GVA stopped at the NTS.
And then I don't understand what is coming out of the NTS.
NTS has neurons in its nucleus. It's full of cell bodies. And those cell bodies have axons, and those axons can go up to the limbic system, or they can go down to the preganglionic
when they go down to the preganglion, what is, it's only GVAs are going down to the preganglion?
They're just NTS neurons.
Like they have their own neurons.
You could call them intermediate.
They're like
Yeah.
GA, and then NTS is the intermediate neuron until it reaches whatever the
Just call it
amount of
switch.
cell body and then it goes to GD.
Let's call it like an NTS neuron. Let's do that.
That could work. If that makes sense to everybody.
So when it gets down here.
So, you get to the NTS, and yes, the NTS could have an intermediate, if you want to call it that, neuron with an axon that goes down to preganglionic autonomic. It also has cell bodies with axons that can go up to limbic structures. Limbic structures have axons that go back down to NTI. So that's why you have all these neurons with their axons that give feedback, but I wasn't calling them like I was when I talked about a 3-neuron pathway. I didn't want to do that because it doesn't work that way. I just wanted to show you how it can be reflex without the limbic structure, or it can have limbic structure in.
I don't know if I was right on email to you, but it helps me think about it, not saying how in the basal ganglia, how you're coordinating the motor movement and the goes back into cortex and goes the motor pathway. So it's like, is the going up the limb is coordinating the emotional whatever here that pathway is coordinating, and then we're going back down in our sympathetic.
Right.
So we're not
Right, sympathetics and parasympathetic, we only call those last 2 neurons. So, what Taylor was saying is that we have the limbic structures are trying to coordinate an emotional response. Always. We're always looking for an emotional response. Right now, perhaps an anxiety response. And so the limbic system can coordinate that emotional response through the NTS to get to the autonomic. Does that help? Okay. See, some people think of NTS. I hope I haven't confused it. And we're only talking about how
If I
many
only learned one
questions.
thing from this review, it will be what the back of Nathan's head looks like.
I'll be happy to, only 4:30, I don't know. I'll be happy to talk with individuals after if they're still confused about this issue. Okay?
An upper motor neuron can
An upper motor neuron
be either contralateral or ipsilateral.
can be correct, can be ipsilon.
The example would be like when you're talking about fast movement, we always see the
Wait, did I show you that thing? Front and back? No, like it's just video.
Patient has spastic paralysis, their right pinky. And,
The lower motor
no,
neuron
not
is
in.
always ipsilateral.
Just spastic paralysis, you said upper motor neuron. And then I can give you several distractors and say, spinal
Just depends
cord,
where you cross. Like,
spinal cord ipsi, spinal cord contra, brainstem ipsi, or
Why are you
cortex ipsi. And the answer would be,
that's why you're in double.
it's the only thing I gave you that would have been right. As it cross till it gets up to the straight. Does that make sense?
Oh, yes, you do.
That's why drawing it out and looking at them, trying to do it in your head, I was just trying to think through that myself. I said, I got that right. Do you have a question? Asking about the nucleus gracilis cuneatus and knowing that, yeah, it's T67 is the split between the two. Well, where in the body is that? Well, thorax is 12, so mid-thorax would be where we're talking about. So roughly in somewhere here. Pardon? Sounds good to me. Might be a little higher, you know. Actually, it would be at an angle. You know, that's roughly, that tells you, that way I know I can talk about arms versus lower limbs, or pelvis, and know that I'm away from that gray area of T6, T7. Okay.
My question is about Parkinson's. You mentioned obviously because of the decrease in dopamine, is it a decrease in both the production of dopamine and the receptors for dopamine, or is it? Because you would think if you had a decrease in dopamine production, you would have an increase in upregulating receptors.
That's a great question. And so the question has to do with, if Parkinson's has to do with reduced dopamine, what about the receptors? Wouldn't they compensate by increasing? And the thing is, initially in Parkinson's, it does increase, but at some point it reaches a level at which it's not working anymore. You can't continue to increase infinitely the number of receptors. And so then you get this tipping point where you start to get these things. And that's where the tremor at rest starts to kick in. And like I said, it's usually on one side. Actually, as this disease progresses, all of these things get worse. And there's actually a cognitive function where people can't even think quite straight. So it becomes a lot worse. But initially, there is compensation like that. It's just that ultimately,
So the receptors don't, I mean, they don't disappear, they just reach a level and they can't create anymore.
right, although you could create, in fact, they've done this with some animal models, they can go in and they can create, by blocking those dopamine receptors, you can create some issues. I was just reading a book, and the guy was 20 feet away from the cop and tried to shoot at the cop and hit the cop in the shoulder, but was very close. And so the question was, why didn't the cop get really killed, basically? And he was supposed to be a really good shot. And so the ME came up and said, oh, I found out the problem. Suspension nigro. Totally wiped out. Guy couldn't control him. So you see, these things come back. Even, in terms of lesions, I do have a couple I can throw at you. Lesions. A stroke in the striate artery. Well, there are multiple striate arteries, but the point is that they supply the area deep in the brain of the internal capsule. And so if you get a stroke there, you can affect a whole lot of the body in a very small area, because these are really small arteries. But unfortunately in humans that happens a lot. So that was one of the scenarios that I gave you in terms of lesions, that it can be the internal capsule because it's affecting a whole lot more of the body. And so I gave you the name of the artery that would be involved with that specifically, and that's all I was doing. Okay, it's a branch off the middle cerebral, if that matters to anybody, but I just care that you've heard the name in case you ever see it again. Forward. Other questions? All right, well, why don't I throw a few of these out at you? Let's see. Jotted this down, so hopefully this will work. Okay, patients dragging their right foot with their right arm is normal. So they're dragging their right foot, their right arm is normal. What is the spinal cord level for the lesion? And I'm asking for a generality. below T7, probably, because you know T7's right here in the thorax, it's gonna be the leg, so it's gonna be somewhere down, lower in the spinal cord. All right, so there's increased muscle tone and reflexes. Where in the spinal cord is the lesion? Upper motor neuron. Does everybody agree with that? Okay, so that would make it the cortical spinal tract in the spinal cord, as opposed to the ventral horn. If this were the cortex, where would the lesion be? Or there was the right foot. It was the right leg. It would be the left cortex, pre-central gyrus on the medial side. Or if I want to be generic about it, superior conservative pre-central gyrus, but since I gave you the homunculus and I made a jerk of myself by sitting over the chair, I would expect you to know the medial side of the leg.
For the, you said it was the corticospinal tract as opposed to the ventral horn. If it was a lower motor neuron lesion, would it have been the ventral horn?
Correct. If it had been a lower motor neuron, it'd be either the ventral horn or somewhere out in the body, outside the spinal cord. Okay. This actually is a situation that happened to a friend of mine. And he suffered a minor stroke. And this is where I wish I could draw it. I don't know if I can draw on the screen. Theoretically, you can. Do you have a dry erase? It'd be so much easier. Throw it, throw it.
Throw it, throw it. Is it blueberry?
Guys, it's try right smart.
Okay.
This already looks like a mess, so.
Oh, you're saying that.
Rod has some nice looking ears.
Right?
Did everybody see my figure? I hope.
No.
Were you drawing the clean board?
It's the best I can do for lining this up. Drawing the clean board? Yeah, I can do that. Now can you see?
Nothing.
I know.
Alright, so we have a lower limb problem on the right side, and we have a different problem on the left leg. Over here we have spastic paralysis on the right leg, and we have loss of light touch and proprioception. On this side, the left side, we've lost pain and temperature. So is the lesion on the right or the left?
Head temperature is opposite.
So if you, remember
Well,
I
that's
gave you a
it,
few
right?
bullet points of how to organize it, first of all, is it head or non-head? Well, it's obviously non-head. But ultimately, you're gonna look for where all the paths are together. So, where do these things, well, first of all, spastic paralysis is what?
Upper motor nerve.
So it's motor and light, touch, and proprioception. Dorsal column. Where do they cross the midline?
The lower medulla.
It's gonna be up in the brainstem. But notice that the upper portion of the body is not affected, so this has to be a lesion before they cross. Where is, pain and temperature, where does that modality cross? Immediately. So where are they all together? Which side? On the right. So that's the answer. So this is a spinal cord lesion on the right side. At least that's what it looks like. So is there any way the cortex is involved? Yes. It was a stroke. Was the cortex involved at all? Is there any way? She could move it, but it was spastic paralysis initially, and then she got some movement back. So it was a minor condition. Think about this though, and I was talking about this a second ago, if say either one of these, the motor or the dorsal column, they come up to the brainstem, that's when they cross. So if it's at this point that they're crossing the midline to go up, then pain and temperature continues because it already crossed, didn't it? So then it would be on opposite sides of the brain. So there's no way it can be at the point of the brainstem after they've crossed, or in the cortex, where you'd involve both sides. Does everybody see that? The attending physician said it was a brainstem stroke. Fortunately, he wasn't her neurologist. So this was actually a spinal cord, had to be in the spinal cord. That's where they all are. And fortunately, it was minor for her, and she was able to recover fairly well. But she talked about this experience. She had difficulty walking. She had to kind of relearn how to walk, and without the proprioception, she was a little unsteady gait, kind of back and forth like this. And she complained about getting into the tub because she didn't want to use the bad leg because, you know, if you try to stand on a bad leg, she'd fall. But if she put in the other leg, it hurt because of the pain and temperature responding to the hot water. And so she had this either way, you know, of what do I do? I have one leg with this problem, I have the other leg with this problem, and but it made sense in terms of the path. All right. If you have a lesion in the inferior 1/3 of the post-central gyrus, what would you notice? Loss of just basically all sensation to one half of the face, right? What if you have a lesion located in the same 1/3 inferior portion of the pre-central gyrus, what would you notice in there? Pardon? You would notice you wouldn't notice a whole lot, but you would have paralysis on the eyebrows down on one side of the face. So it would be the side opposite the lesion. So if I said it was the left side, the face would be affected on the right side. But that's the only thing you do.
Why was it, is it the eyebrows down just because of the bilateral innervation versus the contralateral innervation?
Correct, the cranial nerve 7.
Or cranial nerve seven?
Cranial nerve 7, so the forehead would be just fine, but on the side affected, it would be, you'd lose muscle tone.
Still recording? Yes.
And that was because, although they had one chronic condition, the other above the eyebrows.
You want to hold on my head?
Hmm?
Oh, you're good, you're good. No, man.
Right, okay.
I'm over here now.
What about the,
Well, that's, I was talking about head, but that's going to be your sternocleidomastoid, is going to be your trapezius. So it would be affected contralaterally if that was part of it, sure.
okay.
And I was thinking face. So you'd have, what you'd have is the opposite side musculature taking over. So the sternocleidomastoid would pull you down, you'd tip your chin to the affected side, and you'd have weakness in your trapezius and inability to keep your head straight.
So that sounds like.
Well, those are the ones I just jotted down. I can't, oh, I've got one more. I thought I have margins here. We'll stick with this person, but we have loss of pain and temperature to both legs. Where's the lesion? Where? Loss of pain and temperature to both legs.
Is that like that white measure area or something? Anterior white measure?
Anterior white commissure, you got it. Very good. That is called syringomyelia. You don't have to know the name, but this is a real condition. It has to do with the central canal, and it starts to swell up. As it swells up, it impinges on the anterior white commissure, which is where the pain and temperature fibers from both sides are crossing. That is the one place they come together. And so that's how you get bilateral loss of pain and temperature. I didn't think so. Oh,
So if you did know that, you're just a huge nerd.
When did you make
That I didn't talk about it. I didn't talk about this condition.
Yeah, when did he mention?
Maybe it's on somewhere in the old stuff, right?
That's in the next, I didn't mention that in the track.
Huge nerd.
How did you know that?
Ooh.
Wait, Madison. How the hell did you know that?
No, she read the Facebook. She read the
Ray.
No.
Just one night over dinner, he mentioned it.
I may not have mentioned it in the Pathways lecture. I should have, but I may not have.
I think it was in the lesion lecture. Possibly.
I've never heard that.
Okay, well, learn it. You're here. You never know.
Talking about fairness here, Madison.
Okay.
If you didn't know about the anterior white commissure, you wouldn't have been able to answer that, or at least not very well. You should have known that they're crossing at the same level. You might not have known where. So I couldn't have asked you. So it sounds like I didn't use the anterior white commissure, and certainly if I set that up by saying the central canal expanded and impinged itself on which of the following structures, that wouldn't work. Apparently I didn't give it to you. But I could ask you at what level, because at that, you should be able to figure out the crossing at that, it's the only place to come together. You just wouldn't know where. Other questions?
Instances where you said you could cut one of the nerves, but the other nerve is compensate the other side, is that the thing?
Yeah, I'm not sure exactly what you're referring to. When I talked about paleo, I said that there's a small bilateral input. When I talked about cortical bulbar,
Individual questions.
you've got both sides covered most of the cranial-motor nuclei. And one of the students, his name Lynn, mentioned, don't you have some weakness on one side? And I said, well, the reality is yes, but for the test, don't worry about that. We'll just consider it, it would be just covered. I'm not gonna talk about weakness to one side or the other. I just say you wouldn't have a problem.
So the question we just talked about with the, being paralyzed from the eyebrow down on one side of the face, what would make that?
That's cranial nerve 7.
So any other cranial nerve, it would just be covered?
It would just be covered. Yeah, 7 is one of the exceptions. Okay?
Cool.
If anybody has some questions they
That just made me more confused.
didn't quite want to ask, have you entertain them down here. If anybody has NTS questions, they want to ask some more, I'd be happy to do that